Hello, everyone, and welcome to the Winter Salon with the AAEM Critical Care Medicine section. I'm Andrew Phillips. I'm going to be your MC, and unfortunately having to fill in for William Teeter, who can't be with us this evening. I will try to be 1/10 of the researcher and physician he is, and if I can pull that off, I'll be doing a good job.
You have to get down. Mama's going to tell you you're in bed. Rosie's in bed, Mama.
All right, so as we get started, please go ahead and make sure that you're on mute, and let me go ahead and introduce some of our speakers. So Dr. Wendy Chang is with us. She's going to be representing the Neuro ICU, and then we have Dr. Daniel Lurcher. He's going to be representing the PICU. Next, after that, we have Dr. Colin McCloskey. He's going to be representing the CVICU, and then I'll be representing Bill Teeter with the surgical ICU. We have panelists, judges, who are going to be listening in and being the prepared peanut gallery, if you will. And so that's going to be Dr. Allison Hines and Dr. Mike Winters and Dr. Harmon Gill as well. So, and I'll be intermittently there, but then not really, since I'm also taking over for Teeter. So with that in mind, with the sequence of what we're going to do is change things up because none of our salons are ever the same. We're going to do 5 minutes of each of the presenters. First we're going to go 5 minutes of speaker presenting their article and why they think, and here's the question that you as the audience will be voting on as well. Why is it the most practice changing or research changing article in that specialty? And at the end, we're going to vote on which of these papers in different areas is the single biggest changing paper for any of us to know about. So they're going to give 5 minutes explanation of what that paper is and why they think it's so important. Then the panel judges are going to have some questions, and then we're going to open it up to the group to be asking questions as well. Now, the whole reason we're not doing the webinar thing is if you have something to say, an extra question, go ahead and jump in, even if the panelists are doing their questions. This is supposed to be a fireside kind of conversation. And so with that, I'm going to stop and kick it right on off to Dr. Chang. If you could actually maybe give a short introduction where you're from and some of your, where you're from and where your favorite AAEM conference was, and then kick it off the article. Dr. Chang.
Awesome, very good, thank you. Thank you for joining us tonight. So I am at University of Maryland, and I certainly practice both in the ED and the Neuro ICU. I would have to say my favorite AAEM conference is yet to come, because in 2022 we'll be in Baltimore. So I hope to see you all there. It was hard to pick an article, definitely, to highlight, but I thought hard about practice changing. So I had to talk about this meta-analysis about the use of IV TPA thrombolysis in patients who are presenting with unknown time of stroke onset. Since there has been a few trials that was done on this, and I think this meta-analysis really gives us just a better look at the data, because there was certainly a lot of criticism for the prior existing trials. So the authors ended up combining 4 of the more recent trials, looking again at IV-TPA using like neuroimaging to select patients who were presenting with unknown time of stroke of onset. The majority of these patients, there was like 843 patients. Majority of these patients, about 90% of them, were all wake-up strokes, which is important because really when we're talking about treatment modalities for patients with strokes, up to a quarter of these patients that we see in the ED actually are not eligible for any treatments because we don't know their time of last known normal. So this particular population was kind of your medium stroke severity. They were presenting with an NIH stroke scale a median around 7. And about 25% of them actually had LVOs, 40% or so had other vessel occlusion. So also patients who could have been eligible for other treatments as well. And ultimately, after combining 4 of those recent trials, they found that IV-TPA did have a higher favorable outcome, and that was defined by a modified Rankin scale of 0 or 1, 0 meaning no deficits at all, 1 meaning very mild deficits, but able to do everything that they were doing pre-stroke independently and well. And that really gave us a number needed to treat of 12. So I thought that was quite impressive. And the other outcomes they looked at, there was a shift towards better functional outcomes. There was a higher proportion of functional independence. As you can imagine, though, of course, if you're treating more patients with TPA, you could have, and they did see a higher rate of symptomatic ICH, as well as a higher rate of mortality. But I would say that all of those reported rates of 3% symptomatic ICH and 6% mortality were similar to prior studies that looked at TPA in kind of your classic time windows of treatments. So just the fact that these patients were presenting with, unknown time of onset, once again, because of the use of imaging, whether it's MRI, perfusion imaging, et cetera, to really identify those who are most at risk and has the most salvageable tissue, it really helped, reduce the potential risk-benefit analysis that we're always considering. So I think it is practice changing. And in fact, these have already made it into these stroke guidelines. Although I think probably across the states and such, and institution-wise, we have not quite seen it change our particular practice just yet. So even in the 2019 American Stroke Society guideline, it was already included a line about the Wake Up Stroke study, not inclusive of this meta-analysis yet, that said to consider the potential use of IVTPA in people who were presenting, again, with wake up strokes with a demonstrated kind of this at-risk penumbra by neuroimaging. And the European Stroke Society, their most recent 2021 guidelines have included this meta-analysis and the existing trials. And they also share that this is, moderate to strong evidence for the use of IVTPA, again, in this group of patients by the neuroimaging selection. So I think as we've seen from, all the thrombectomy data, it's really about finding the right patients who are the best candidates for reperfusion in acute stroke. And I think with the tools that we have nowadays, with actual imaging demonstration, again, of at-risk tissue with a small infarct size, we really can identify people who are eligible for not only thrombectomy, but maybe also IV thrombolysis. So.
Wonderful. Thank you, Dr. Chang. All right, Peanut Gallery, fire away, along with anybody in the audience. If you have questions, comments, let's challenge Dr. Chang as to why this is the most important article we probably missed during the pandemic.
So Dr. Chang, I'm interested. The thing that I key on this particular article is the use of perfusion imaging in trying to help kind of individualize and select those patients that are going to benefit from this therapy.
Yeah.
Now, obviously in Wake Up, that makes sense because they're out of traditional windows that we think of for thrombolytics. Is there an argument against using perfusion imaging in all comers to better individualize? Because the risk of thrombolytics is going to be there kind of across the board.
Mm-hmm.
If we more widely adopted perfusion imaging, could we be more selective in getting the benefit and dodging some of the risk?
It's a really good question. I think it definitely can help better, again, risk stratify, as you mentioned. I think it adds the additional benefit in these unknown times because of the fact that we just really don't know, are we dealing with a true infarct that is, let's say, 6 hours out versus 12 hours out, right? And it has better sensitivity than, of course, a non-con CT. And so I think with the patients that are presenting with, I think, in similar to these patient population, moderate stroke size, et cetera, that the timing is pretty exact. It obviously does add also on to the time that it takes and potentially delay the treatment itself, right? And so that's kind of the risk benefit that I also have to consider. Would that really change that risk benefit ratio that much if I were to get a perfusion imaging and rather than proceeding directly within the current time windows? So, yeah. I think we do have, though, more and more of this data that just because of how all of our practice patterns have probably changed since the thrombectomy kind of this trials. At least I know that when people are presenting within, let's say, your traditional 4.5 time window, people are getting their CTA and perfusion because you're really looking for LVOs at that time, right? And so you have that same information there.
Wendy, I'll throw out a softball. I hear
Mhm.
at the University of Maryland that there's a fairly aggressive stroke team that when patients present to the emergency department, there is very active and robust response with an aggressive take on thrombolysis. Has your institution really taken hold of this paper, and what is in collaboration with the neurology team, the stroke team, and neurocritical care done with this information here and its approach to the evaluation of patients coming in with acute stroke-like symptoms to the ED?
Yeah. We have not adopted it yet, but certainly, again, adds more fuel to the discussion. I know that when things first came out, we definitely talked about the application of thrombolysis with wake-up stroke. So I think it's time to revisit now that we have more of these trials and this meta-analysis to kind of support, or at least just simply more information. I think one of the caveats that a lot of you guys probably are aware of is that the reason this meta-analysis gives us a potentially better look at this question is because Wake Up's trial, as well as the other 3 trials that are included, they were all stopped early because of various reasons. And so that really just didn't give us, of course, the power that we wanted to answer the question better. So.
I want to toss in a question representing, because I work in a single physician coverage rural hospital. We don't have an MRI for, gosh, an hour and a half at least. So I mean, the vast majority of this was MRI. Am I supposed to, is it still reasonably a thing to be changing my practice with just what I get off perfusion? Which, by the way, getting a scanner in the actual facility was a new thing in the last year.
Amazing.
You had to go across the street. So are CT perfusion results, you think, sufficiently valid to take an article like this? It was like 85% MRI. Should I be doing that?
Yeah, no, I think that it is definitely the design of some of these trials that they were MRI based. Some of them also looked at, of course, perfusion based. And MRI wise, there was both the use of diffusion versus flare as kind of your ischemia versus infarct comparison versus MR perfusion. So I think perfusion is perfusion, whether it's CT or MR based, uses software to quantify, this at-risk area for us. Whereas at least in this trials that we're using DWI versus flare differences, it was either a visual comparison or kind of calculated volume comparison. And so I think perfusion would give that same information, CT perfusion, specifically based on what you're asking, because it's more readily available. It still gives this kind of ratio of ischemia versus infarct and give that better risk analysis.
Kind of go off of the patient selection. I noticed that the median NHSS score is about 7 with a kind of like a tight range. Do you see that this only maybe applies to a small patient population, or do you think you can broaden it out?
It's true that it definitely just does not include those who were, in extra sort of 20s, et cetera, that were thinking of full MCA syndromes. Part of that definitely could be that potentially that population had more infarct core, therefore made them higher risk and not the best candidates? Or was it because, at least for the later trial, the ECAS-4 one that was in the realm of after the thrombectomy trials, they were losing, the reason that study stopped early was because of a lot of the other candidates ultimately got thrombectomy, so they were enrolled in the thrombectomy trials. And so I think the same risk benefit analysis using these neuroimaging techniques still can be applied for your large stroke NIH presentations. It just depends on, again, how big of an infarct are we dealing with and what's the hemorrhage risk that we're dealing with.
Dr. Chang, if you will, I want to build on a question that our colleague Dr. Phillips asked. I work in a place where we get a lot of these interfacility transfers from places that have very limited, if any, resources. And since the evening is centering around our COVID implications, COVID itself whether it's testing and transporting, has certainly added further to delays, and getting someone into this 3.5 conventional IV TPA window is just so much more challenging now with COVID. Have you, in your own practice or professional guideline practice or professionals alongside your practice, started to favor a little bit of discussion where there's this interfacility transfer, but to a transfer to a facility where you can do more, just be like, hey, give the lytic, and we haven't had a DWI evaluation or a CT perfusion evaluation because, you know, you don't have that, but you're in a 7+ range of a night stroke scale, and then, you know, we'll do the rest when you get here. Has that really impacted your practice, especially because it's quite remarkable that the study actually points out to a series of safety outcomes of saying IV TPA in 7 hours plus, or versus 3.5 that we've conventionally known. The risk benefit in terms of significant bleeding and stuff was quite remarkably similar.
Mm-hmm. Yeah, I'm sorry, at the very beginning. So you're saying that it is the same kind of a question of people who are presenting, like you said, 7 hours or so and getting transferred to
but
tertiary care.
owing to COVID or owing to, you know, no beds and things like that, you may have a significant delay in transfer, or getting to a place where, you know, you can get this CT perfusion, you can get this MRI study.
Gotcha. I think all of us are probably going to feel a lot more comfortable after we have more, you know, application in with more image guidance, and then.
Okay.
Yeah.
So you're keeping the decision to even push IV lytics till they get to your facility.
Yeah. Yeah.
Interesting. All right. Thank you.
Great questions. Time for one more. If anybody has another question for Dr. Chang. Anybody else? Good article, good conversation.
I'll ask one more then, unless if anyone else has another question. What were your experience like? I know you alluded to in other articles that you've been like referencing. What do they mean by symptomatic intracranial hemorrhage? Does it like require neurosurgical intervention, or I just want a little bit more elaboration?
Yeah, no, that's a good question. It's always interesting to dive into. So symptomatic intracranial hemorrhage is typically graded by like how big of a size in relation to the stroke itself. And so for the ones that were described in this meta-analysis, they were like at least a third of the infarct volume size. So but in terms of, let's say, if you were looking at like mortality related to, you know, the cause of mortality for this patient population, I think in the TPA group, it was about a third or so that were at least attributed to neurological reasons, but didn't comment specifically if it was ICH related.
All right, great. Thank you very much, Dr. Chang. All right, next up is Dr. Lurcher, who's going to represent PEDS. Same thing, your site, and you are a pediatrician by training, since that's what's required for PICU. None of us can work in a PICU. So I guess your favorite PEDS conference location, since you haven't been to an AAEM conference.
Hi, everyone. Thanks for having me and not making me go first. As Dr. Phillips said, Dan Lurcher here. I currently work at University of North Carolina in Chapel Hill at the Children's Hospital there. And my favorite conference, probably the only one that I've been eligible to go to, was in Honolulu. It was pretty fun. I got to present there. And then it's been virtual for the last 2 years, and this year I'm scheduled to work, so the rest of my group can go down in Puerto Rico. So I will, as you can see the article list on the right, I'm going to talk about clinical signs to categorize shock and target vasoactive medications in warm versus cold pediatric shock. And I was hoping that this would pique the audience's interest, because you know, with being the receiver of a lot of calls from across the state of North Carolina, pediatric patients and pediatric shock patients basically scare everyone, sometimes even myself, with how sick they come in. And sometimes they even, within 5 minutes of them walking through the door, we get transfer request calls to get our team on the road to get them transferred, despite not sometimes not even having more than a set of vitals. So that's why I hope this article would be helpful for the group. And so what I found super interesting about this one is in 2020, the Pediatric Surviving Sepsis Campaign guidelines made a kind of a big shift in pediatric shock management, and they warned that clinical signs may not reflect underlying cardiovascular physiology. Basically, we don't do a lot of invasive monitoring for obvious reasons of the size of our patients, and there's been more risk than benefit up to this point. And so we do a lot of physical examination to kind of pride ourselves on our physical exam skills. But so when these guidelines shifted, it kind of put a big question mark. Okay, what are we supposed to do? And so one of the big children's hospitals up in the Northeast tried to at least answer a little bit of that question. And so this study looked at warm versus cold shock and looked at the clinical signs to aid in categorizing shock, and then matching a vasoactive to said physiology. And so they followed their institutional sepsis and shock pathway. And then for their warm shock pathway, they looked at did the group start, or for the patient, did they use a vasopressor, and for cold shock, they use an inotrope. And I'm happy to go over the choices, but mostly it was their two drugs of choice were dopamine and epinephrine most commonly. So it looked at the interrelated reliability of the clinical signs of shock. They looked at 5 different clinical signs, and then also looked at the IRR of the choice of vasoactive based on the shock type. It was not a large study, as is typical for most pediatric studies. It had 469 cases over about a 4-year period that met their inclusion criteria. And there's more warm shock than cold shock, as most pediatric cases are. And of those, 86 of them required pressor usage that met their inclusion criteria. And I won't bore everyone with the exclusion criteria. So what was interesting is that there was poor agreement across all 5 clinical signs. And this is Dr. Phillips' favorite statistical analysis, which is kappa. And I learned all about that recently, doing some work with him. But what was fairly good agreement was extremity temp, cap refill, and pulse strength. Which did not have good correlation was pulse pressure and diastolic blood pressure. Then they looked at, for those patients treated with a vasoactive, neither the shock type nor clinical signs were strongly matched with the vasoactive. So that was interesting that, despite that they may have categorized the shock correctly, that they did not choose the pressor of choice based on their institutional algorithm. But what the most interesting part of this whole article was when there was shock type vasoactive mismatch, they looked at 2 clinical outcomes, one at 7 days, which is 2 or more organ system dysfunction, and death by day 28. And what was cool is that there was not an association with increase of a complicated course, meaning there wasn't any increase in 2 or more organ system dysfunction at 7 days or death by age 28. So take home message from this article is, after appropriately fluid resuscitating these patients, try to pick the most appropriate pressor based on your presumed physiology. But don't feel bad if it is less than ideal, because even one of the most preeminent children's hospitals didn't choose right all the time, and there was no increased risk for a complicated course. So there we go. And as Dr. Phillips said, why would this be a missed article for the group? Is I don't think there's any other people who work in a PICU or probably know a ton or take care of a ton of patient shock, because on average, when I kind of looked at EMs that take care of, a wide range of patients, don't have a standalone children's hospital, the average is 2 to 4 shock patients, pediatric shock patients, a month at most.
Great, Dr. Lurcher, thank you very much. An informative article, and yeah, we were talking ahead of time, so I have some opinions, but I want to open it up for other people to launch some questions for Dr. Lurcher.
I'm interested because I don't take care of kids, even in my EM world. We have a standalone children's hospital, and thank goodness for that. But it's interesting because for adults, like both cardiogenic and septic shocks, you're warm and cold respectively, like a single agent norepinephrine is actually the recommended first line by either guidelines. So we're not faced with this choice of, which one's better, like the dopamine epi that, the pediatric providers had to face. Is there a rationale for that kind of split in the road in your population?
I think for the most part, traditionally, because let me take a step back. Different groups use different vasoactives all the time. Like the NICU uses, they're very dogmatic, and they start dopamine first line all the time because that's what their big trial said, and so that's what they do. And then their second agent is usually epinephrine. Then they use dobutamine, and they kind of max dose those. And so it's, and then in the PICU, we're first line epi for most everything because it's probably most readily available to us, and it's but that kind of fork in the road, it gets into the art of doing some of these things. And like I said, we kind of pride ourselves on our clinical exam skills, and think that based on the pathophysiology that we can match the pressor, but it is probably getting too cute to try and match it appropriately. And at the end of the day, it's appropriate fluid resuscitation up front, and then basically picking what you have available and getting them to a center as quickly as possible. I hope that answered your question.
Is there a reason why me as a country ER doc, if I had a shocked kid, which due to how I've curated my practice should not happen, is there a reason why norepinephrine would be excluded? Because that was not one of the vasoactives you just mentioned. You said dopamine, epinephrine, dobutamine. Is there data suggesting that that's not the right go-to? Because I think for a lot of EM physicians, that's the go-to that everyone's comfortable with in the adult population.
Yeah, I think, honestly, I think where all of the basis is, that's where how the trials were done with epinephrine. They were done with dopamine because that's what we thought was the best choices to begin with. So that's where all the studies were from. And norepinephrine was not used as much. And so that's just what the data we have. I don't know of any data that says there's it's an inferior choice. But what was it, like I said, what was interesting in this article is that it really did not matter the choice of pressor. If a pressor was needed, it was get the blood pressure up to where it needs to be.
If I may, that was my difficulty with the takeaway from this was it's probably not going to matter if you're using epi, because epi has both. I was really surprised that epi counted as the inotrope, because come on, we all know there's plenty of alpha in there as well, right? And then to call norepinephrine just a vasopressor, but there's some decent beta in there as well. So I guess is the takeaway I came from this was just go with epi. You can't go wrong. Is that an inappropriate takeaway? You cover them all?
No, because that's what we use most commonly as first line is epinephrine. But yes, it's not clean. I don't think any of these drugs are super clean, except for phenylephrine, vasopressin. I think there's a lot of crossover in the other ones.
question.
Anyone? Oh, good.
I think as someone who sees some sick kids, hopefully nowhere near 2 to 4 a month, I think what's remarkable about this paper is that in comparison to all vasopressor studies that at least I've come across recently and in the distant past, we all intellectually destitute the physical exam. We want numbers, we want maps, we want SCVO2s, we want invasive monitoring of all sorts. And I think whether you're coming from afar or you're at an academic place, the reliance of physical exam findings in a contemporary research paper is quite enlightening and refreshing. As someone who then, on the flip end, sees so many of these sick kids who need epinephrine or whatever other medication, and thank God for people like you, do you find these physical exam findings that they looked at, or the ones that they found pertinent or not pertinent, do you agree, disagree with them? Is anything surprising to you?
No, not at all. That's what I've always been taught and I've always practiced is cap refill, cap refill, cap refill, heart rate more, in kids, they can compensate a ton with heart rate. They don't have the ability to compensate with blood pressure, increasing their SVR. So it's heart rate, it's cap refill, and, basically overall, end organ perfusion. So I was not surprised at all with, the signs that they looked at. That's the first thing I do when I walk into the room, when I get called to evaluate a patient in the ER or in the PICU, is I put my hand on their foot to check a pulse, check cap refill, and see if they're cold or not. So that's, those are the first things I do. I love invasive monitor just like the next person, but sometimes, we don't have an art line all the time, or we don't have all of this stuff. So we use lots of NIRS and whatnot, and you can get a good idea of how the patient's doing at the door. But, there is nothing that in my opinion, replaces, hands on the patient. And so I was again, I agree that it was really nice to see someone looking at that because of all of the advanced stuff that is being looked at these days.
And then if I may follow up, Andrew, do I have time for another one?
Yeah, go right ahead.
So then, clearly with that physical exam finding, with the lack of readily available insertable pieces of invasive plastic in these little ones, there's clearly also a fork that Colin was talking about things like epinephrine that should likely probably go through a dedicated central line versus something like dopamine that, a lot of people have a significantly greater comfort and availability peripherally. Do you have a take on sort of this world of peripherally started vasopressors versus centrally started vasopressors in this kid world?
Yeah, there was actually a really good study, probably about 2 or 3 years ago. I can't remember the author at the top of my head, but they actually looked at this exact question of, especially with patients who were at non-children's centers or non-pediatric ERs, is running. They looked at epinephrine, they looked at dopamine, and they looked at adverse events, and they actually look at concentrations. And so they did actually, it was head-to-head dopamine versus epinephrine for sepsis in these patients. And they actually ran much higher doses of epinephrine than we ever run peripherally, up to 0.3 mics per kilo per minute. And there were better outcomes and no increase in adverse events, like with limb ischemia, if there's extravasation, et cetera, is a big thing to worry about. And so it kind of, I think the duration was up to 6 hours that they looked at. So, it's one of those things that if you need to start it, you can. Obviously we prefer a central line when we do these things, but you can get by with a in my opinion, a very high dose of epinephrine peripherally. And I'm happy to find that paper if you're interested.
Yeah, that'd be great. Thank you.
Dan, I have a question for you. I totally agree. I love the idea of lifting up the the sheet, feeling the foot, feeling the extremities. I think that is so valuable. But I'll tell you, the next thing that I do if I feel cold extremities, I pick up the ultrasound. Has that entered your pediatric world as much as it has our adult world, to do point of care ultrasound and echocardiograms to further figure out if this is warm or cold shock or a component of cardiogenic shock?
It's yes, with the caveat. It's one of those things we are trying to work with our EM colleagues down at Children's to implement a curriculum and to do, and obviously our fellows do a lot more of it than we do. But yes, it's not quite as abundant, but that literature is starting to come out as well.
Great. Any more questions from the audience? Love the question, audience. Thank you, Dr. Lentz, who's, by the way, the chair of the section. So thank you for speaking up, Dr. Lentz. We all know sick kids are concerning to us. By concerning, I mean scare us greatly.
I will say is, I took care of a 20-year-old recently, and she behaved more like this, like you're describing, this cold cardiogenic shock from some stress cardiomyopathy. And it was enlightening. It gave me a new appreciation for a paper like this. She behaved very much like a child more than an adult, based on her ability to compensate, despite really, I think what an older person would have just immediately fallen apart and died from. So great paper.
Good point. All right, well, thank you very much, Dr. Lurcher. And next in the parade is Dr. McCloskey, who's going to talk to us for his paper representing the CVICU. And so, yeah, your facility and your favorite AAEM location or AAEM conference location, please, Dr. McCloskey.
So I come from University Hospitals Cleveland Medical Center, and
Hi.
Cleveland's fantastic. So you should all visit. My favorite AAEM was probably my first one. And that is not because it was in Las Vegas. It was because of the quality of the content and the colleagues I met there. But it might have been because it was in Las Vegas. Let's see. So I'm going to talk about, and I'm going to share my screen real quick. So everybody sees the slide? Yes? Okay, cool. So I did the Do-Re-Mi study, which is dobutamine versus milrinone in adult cardiogenic shock, not peds, thank goodness. And the reason why I think this is practice changing is this is such a relevant conversation on every one of my rounds in the CTICU. That is the flavor of shock that predominates, which is cardiogenic. And it always kind of comes down to what inotrope do you want to use? And it's very tribal. Depends on your institution or depends in which manner you trained. I'm anesthesia critical care trained, and cardiac anesthesia loves their milrinone. But if you were in a cardiology program or you did a lot of CICU time, dobutamine's the go-to for that particular tribe. So this has always been an open question that people would stick to their dogma and stick to their tribes, and now we have a little bit of literature kind of speaking to like the strengths and or weaknesses of one versus the other. However, it probably says more about tribalism than a particular inotropic medication. So just so we're aware, cardiogenic shock, when you get to like the upper levels of the SKY criteria that I'll go over in just a little bit, approaches mortality of 50%. So we're very keen on finding interventions that can move the needle here because the mortality and morbidity is pretty high. This is the SKY criteria. This is the Society of Cardiology, Angiography, and Intervention, all the people who cath and do PCIs. So at the bottom is anyone who got admitted to a cardiac ICU. So this could be your general CHF human all the way to someone with cardiogenic shock. And these make up the majority of folks in the SKY classification, about 50%. But the folks that the cold shock that's classically taught that we've been talking about earlier is really this classic category. That's when when you have invasive monitoring, you're going to start seeing some hemodynamic perturbations, elevated filling pressures, decreased cardiac output, cardiac index in this scenario. And it's really in this classic or sky type C area that we're starting to think about inotropes in a meaningful way. When you get up to D and E, that's when we're talking about failure of inotropes and endomechanical circulatory support. But a lot of the movement is here in this kind of classic that we all kind of recognize. When it comes to the actual mortality, though, it's in this classic where we're starting to get a lot more interested. The folks in the A and the B risk, really, you're going to do fine as long as you don't do something iatrogenically to them. In the C is kind of the tipping point of when we're going to start moving in that direction. And the reason I bring this up is that you needed to be a Sky C insofar as cardiogenic shock to get into this trial. So just you have an idea of who these humans are in the spectrum of cardiogenic shock. So we'll do a little PICO to go with the Pellegrino that Dr. Gill is guzzling down. The population, so for these humans in this trial, you had to be 18. You had to be Sky B through E class, but the majority were C. You had to need inotropy despite having some modicum of vasopressor on, and people thought you were fluid resuscitated, right? You couldn't be pregnant. You couldn't have an out-of-hospital cardiac arrest. That was not a human. And you couldn't be biased towards a fave inotrope. So if there was a physician that was like, nah, I'm a Miller-Gnome dude, like, obviously you couldn't be randomized because they would overcome that. There are some pre-specified subgroups that Dr. Phillips will be interested in: age over and under 75, RV versus LV, like which ventricle is failing, ischemic versus non-ischemic causes, gender, and then a variety of other a priori subgroups. The intervention was Milrinone. The cool thing about how they did the dose adjustments is they did it in stages, like stage 1 through 5, like a gear shaft on a like a manual transmission. Like you'd be like, we need an inotrope, start stage 1. And then the randomization would either go from Milrinone, that's 0.125, and then you go up sequentially in 0.125 at like increments. But you'd be like, I'm ready for stage 2 or stage 3. And it went all the way up to stage 5, which is over 0.5, which is a healthy dose of Milrinone. Right. And this was blinded to the physicians, blinded to the outcome assessors, wasn't blinded to the bedside nurses because they have to actually touch the pump. Fair. The control was dobutamine, and these are doses from 2.5 all the way up to 10 to give you an idea of like kind of the dose ranges that we're talking about. The outcomes that they looked at, this was a composite outcome, which is nice because it allows you to have a smaller sample size in order to get adequate power for your primary outcome, although it is a smorgasbord in that it was a composite of in-hospital cardiac death, cardiac arrest, need for transplant or mechanical support, MI, and like need for renal replacement therapy. Those things are not all equal in my mind. I would much rather be on a dialysis machine than die, but with the composite outcome, that's kind of the problem. It's kind of a sausage of endpoints. They did have some secondary outcomes that looked at safety, arrhythmia being one that they looked at specifically with dobutamine, and then they had a variety of biochemical and hemodynamic secondary outcomes. When it looked like, does Milrinone crash your pressure, which is usually the counter argument against its use. All right. Oh. So who is actually in this study? These are 70-year-old white dudes for the most part. And they had ischemic cardiomyopathy. Most of them had prior MIs, and their EF was about 25%, 80% Sky C, as I said before. And one of the bugaboos of the study is it took about 20 hours from ICU admission to actually randomization and getting study drug, which is a pretty long time to be in cardiogenic shock without an inotrope, but fair enough. I'm not judging, I'm just observing. Their sample size calculation, just for you folks, you stat nerds on there, they thought their event rate for that composite outcome was 55%. That was based on a meta-analysis, alpha 0.05, 80% power. This is always a problem. They thought that Milrinone was going to reduce their composite endpoint by 20%. No, I don't. That would be if I was a pharmaceutical rep, I would like try to harangue somebody into believing that any intervention would reduce a composite that includes death by 20%. That's just not statistically going to happen, but this is what they used for this trial. And as a result, your sample size is 192, which for cardiogenic shock isn't a bad trial size, but not huge, not certainly a mega trial. So this is the primary outcome. So they had 192 patients, 96 in each group. That composite outcome, there was no real statistically significant difference between milrinone or dobutamine. When you look at some of the secondary outcomes, arrhythmia is a bugaboo that all the cardiac anesthesiologists will say is the reason not to use dobutamine. Wasn't a statistically significant difference there. Further, there was no increase in hypotension in the milrinone group, which is the the counter argument against its group if you're a cardiologist. And all of the a priori subgroups were underpowered, but there wasn't a huge outlying signal when we looked at this. So the too long didn't read for this is that there was no clinically important outcome difference between milrinone and dobutamine in this middle of the road SCI-C cardiogenic shock cohort. And so I really can't make fun of my cardiology colleagues for always being dobutamine fans because I don't have a leg to stand on in as far as this single center RCT for favoring milrinone blindly.
Great. Thank you very much, Dr. McCloskey. And let the games begin. Fire away, guys. What questions do you have for him? All right, I'll start because I got two burning questions. And forgive me, I'm not trying to be a jerk, but I read this paper and I look at this and I never, with the capital N, start dobutamine or milrinone in the ED. I do plenty in the ICU, but in the ED, they're, to me, still so labile and undifferentiated that maybe I'm starting norepinephrine, but I'm often starting epi for the same reason we're talking about with the kids, that if I'm wrong, I'm hedging my bets by starting epi. So I kind of read this like, well, I don't use either of those agents in the ED. And I'm not sure I would encourage emergency physicians who aren't comfortable with regular critical care to start either of those, given that they can cause some hypotension. Both of them, obviously kind of similarly as shown in this study, but you got to kind of know what you're doing to start those drugs. The second thing I really noticed from this, because I do the ECMO stuff and the post-cardiotomy patients, is that these are not post-op patients. So I'm wondering from your take, I am not reading this paper and going like, yeah, all those patients who come out of the OR after being on pump for like 3 hours, I feel like that might be a different RV that's giving me the middle finger, but I'm taking that from the Journal of Anecdotal Medicine. So I'm looking at this like, how am I going to use this in the ED or in a post-op, CT ICU?
So I agree with your point in the ED. Generally, when folks ask me about cardiogenic shock and what should I use, I'm like, go with what you know, because it's more about your comfort and actually executing the plan than it is about like sexy medications like milrinone or whatever. So I agree with that point. I also agree with, post-cardiotomy patients, are they in fact different cardiogenic shock? You could make the argument that they are. However, like there was no signal here to think that you would treat them any differently one way or another. And there are not great studies looking at dobutamine or milrinone in that population. So this is the kind of the first RCT looking at this where it looks all right. Now, I'm still a milrinone fanboy. I think for the right ventricle was underpowered in the study, that subgroup. So I can't really say that it isn't effective. And my cardiac anesthesiologist folks who are looking with TEE and apply milrinone and then see with their eyes that it improves that right side. I'm not gonna argue against that echo-derived anecdote, but you're right. This paper doesn't answer that particular question.
All right, thank you very much. All right, so I broke the ice. Go ahead, guys. What else?
So I have a question. As someone who doesn't practice in a dedicated CVICU, but we frequently have to convince our cardiac anesthesiologists or cardiac critical care people that perhaps it is the heart and sometimes it's not just everything else. I find this study just very confusing. First of all, in classic New England Journal of Medicine fashion, I don't think this should be titled treatment of cardiogenic shock. I think it should be titled treatment of ischemic LV dysfunction and class C, as you said. But what is your take on the fact that if you look at both figure A table, figure 2, picture A and B, milrinone and dobutamine overall as their hazard ratios, they're not statistically significant. But if you look at their median length of stay, which is about day 16, that's when the curves really start to differentiate and start to show some significantly divergent effects. I mean, in hospital death from any cause, I mean, milrinone after day 16 sort of stays flat, whereas dobutamine continues to go down. And in table 2, the median length of stay in the hospital is anywhere from like 6 to 27 days. So I wonder if they did a 30-day outcome, which is what I would imagine most people would care about, that they left after a month, that I wonder even if this very truncated conclusion would be actually statistically and clinically different. Your take on that?
Yeah, so it's interesting. There is certainly previous data looking at like longer outcomes, especially when it comes to cardiogenic shock. I mean, if you look at some of the primary PCI papers, you actually saw it at the 1-year follow-up and you didn't see it at 30 days. So maybe there's something about, the care we do of the LV and, preventing remodeling, all those things that actually might be seen at a longer time point.
Mm-hmm.
So I think that is insightful. Now, as far as why at day 16, is there a difference? Well, if you're buying in this kind of remodeling and myocardial work, there's something, longer on. Dobutamine pretty consistently increases the myocardial work and the myocardial oxygen need of the myocardium more than any of the agents tested, including milrinone. So there would be a physiologic reason why, say you apply this drug for a week, you may see some later changes as the ventricle, as a muscle is failing chronically. But that's purely speculation on my part.
One more, if I can. The paper talks for the first time, I think, in any of these cardiology papers about the impact of lusotropy. And, then there's also in figure 1, the concomitant vasopressor use. Now, I'm sure you cardiac folk love your mil-vaso combinations. It's not just at any time just milrinone or just dobutamine, it's that plus something. I didn't get a chance to, because I'm weak, look at the supplements. Was there a particular concomitant vasopressor that was preferentially used in this study, or was that another sort of confounder in this study? And your thoughts if there was a particular one?
That's a good question. I know that there weren't differences in folks who were on vasopressors or not at initiation, nor was there a big change in like the vasopressor inotrope like score, which is a way to like kind of quantify. If you added milrinone, did you need to go hella up on your vasopressin or whatever? That wasn't seen, but I'm actually not certain the actual constituent vasopressor of choice in the study.
Clearly, Skylar was taught well.
I'm just commenting in the chat. I use a lot of dobutamine in my practice. We're sort of the mixed CCU MICU, and I like it because it's quick on, quick off. Is why I like to use dobutamine, at least in the beginning. I have nothing against milrinone, and maybe I'll use it more after this paper sort of shows equivalence in many outcomes. But for the reasons that Andrew first stated, in the especially in the emergency department, I like a quick on, quick off medication, and I think dobutamine gives me that more than milrinone in practice. But in this study, it didn't really necessarily show more hypotension or side effects. So seemingly equivalent, but I feel better about recommending dobutamine to people that may not be as comfortable with inotropes as opposed to milrinone. But maybe that's just my own fears or preferences, or tribe, as you say.
I think it's a valid point, right? Like I see this argument as a lot like, when we argue about NO versus Flowland, right? There are clearly tribe specifications and tribe preferences. And I'm sure Daniel Lurcher must feel this love as well, not to ostracize him from this conversation. But it's good to just know, be like, do what you have available. And in the ED context, I bet, it's far easier to get dobutamine than milrinone.
On that insightful comment, sorry to cut you off, Dr. Gill. We have just a couple minutes left, so I'm going to turn it over to, myself, Dr. Teeter, covering for Dr. Teeter. But with 3 minutes, I want to make it quick. And Dr. Hines is going to cut me off very briefly. So the paper that Dr. Teeter had selected is Caught in the Crossfire, 37 Years of Firearm Violence Afflicting America's Youth. And when we talked about it, he expressed that it wasn't that this one paper, he selected this not because this is the one paper that's practice changing, but it's representative of a series of papers that have come out in the last year and a half during COVID, which was interesting in the context of all of the school shutdowns, the decrease in firearm violence. And then once the schools opened up, we saw, of course, a litany of additional violence. But these papers, and this one in particular, was actually looking through data even before COVID and such. And what they did is they looked at FBI data for 37 years, up through 2016. They looked specifically at youth that was from a newborn all the way to 25 years old. And they were looking to see what is the pattern of death by various causes in folks of children of this age. I say children of youth of this age over that trend of time over 37 years. And what they, one of the things they point out is that there are limitations because there's not a cross-talking of the data between the FBI information, which is going to be more focused on the legal process and what do they need in order to make a case against somebody, whereas in a different silo is the information trauma surgeons have about the characteristics of the injuries and the ballistics with respect to taking care of the patients. And those two things are too separated. So what they found briefly was that the majority of firearm related homicides were murder or non-negligent manslaughter. This is to say these were intentional deaths, if you will. 98% of them were murder or non-negligent manslaughter. So this is not an issue of, not frequently anyway, an issue of, oh, people aren't educated enough to keep their firearms away from young children and then having an accidental death. That accounted for only 2%. However, 55% of those were non-felony. So they were intentional, but non-felony. And what this breaks down to is if you take a look, somewhere in here, it talks about how, okay, on page 626, it talks about how a lot of the circumstances for this were other circumstances. For children, 37% other circumstances. For adolescents, it said other arguments and other circumstances made up of 10%. A lot of this, it turns out, if you dive further into the data, has to do with either psychiatric issues or just domestic arguments gone awry. And there's a firearm present and it ends up with somebody getting killed. And so what he wanted to point out was that there have been a litany of articles, particularly in the context of just before the pandemic, with the shutdown of, is this my lane or not sort of thing, was that this should be our lane as physicians, particularly emergency physicians. And since he's representing the SICU for surgeons, this is a public health issue. What you'll note in this paper also, they pointed out that the other causes of death, drowning and things like that in youth, have been decreasing over the last 20 to 30 years, whereas proportionally the deaths secondary to firearms have been rising. And so the point that he made, the reason he thought it was changing, not for a research perspective or a clinical perspective, but from an advocacy perspective, we should be owning this issue because it's a public health crisis that's not being addressed. And that's obvious in the sense of the other public health problems being addressed and improving, whereas this one is not. And so I want to draw your attention as well to the August special issue. Actually, WestJam did an entire special issue in August on firearm death and injuries. And one of the things they did that I thought was, or two things actually, that was really important. One is that they brought up the Utstein method of keeping up of CPR. So that's the way EMS keeps track of CPR and outcomes for out of hospital arrests. And so it's very well documented all the way throughout. It's systematic throughout the country on how they keep track of this. And the proposal was, look, what we're missing here is that scene information that then carries into the hospital side. So why don't we apply the Utstein method that's worked so well for CPR to gather data on firearm injuries? And the other thing was that special issue that I encourage you to take a look at, look not just at mortality, which a lot of these articles look at, but also just more morbidity. And we seem to ignore that a lot. And the few papers that are out there, they focus on the death, and there's a lot more morbidity, right? There's still morbidity to be said about people with spinal cord injuries, about vascular injuries to their legs, to their arms, that need to be addressed as well. So he selected this article as an advocacy changing a paper reflective of the advocacy change that we should be enacting as emergency physicians, and to bring this into our lane.
I think that was very well, nicely well said, Dr. Phillips. It was kind of interesting looking back at times with COVID. I think during my time at Philadelphia, when people were kind of staying at home more, we did notice like a very significant increase in the amount of kids that were sitting there taken care of up in our adult trauma surgical ICU. So I definitely noticed a difference during COVID, at least. And I think the population with RAND kind of coming out and giving different grants throughout the United States is now starting to kind of look into a lot more of the social economical factors too that are also at play, as you kind of alluded to. My question, I guess I'll try to give you a low ball since I know you hadn't got a chance to review this. What do you think are going to be the next steps? Because they gave you like this nice, wonderful, like epidemiological type data to kind of say, hey, you know, this is the population, this is the incidence of firearms, this is how much we know of the family members. But what do you think is going to be kind of the next steps after this?
I appreciate the softball. So the authors make a play for or advocate for releasing the ban on federal money going into the research, which I was surprised. There was I was not part of the conversation, but I know there was some debate at ASAP at the October meeting about some of the language that, at least from what I was hearing, if everyone else was a part of that conversation, but it sounded like it was language mostly about we should educate people and do research on the topic, and even that was controversial. So I have to say, I'd agree with the authors. I hope that we can research this like anything else. I mean, we do research on STDs, we do research on other physical abuse, right? Like there are plenty of awkward things that we are responsible to research. If people are being hurt, we should be asking the question why. So hopefully that's part of what's going to come from it. I don't think that's going to happen in the current political climate. And so it's going to, practically speaking, I think end up still being private money and individuals volunteering their time to look it up. The other thing they advocate for is they go towards, at that point, not substantiated by the work that they found at all, but advocate for closing the loopholes at the gun shows and some of the other common things you'll hear on those who are advocating for gun control, gun safety, gosh, any term you use is going to infuriate some people or other, but more regulations on firearms. I think the next, honestly, just reading this and not having chosen it, but having read this, and the sense that Dr. Teeter was trying to make is the research we ought to be. Why shouldn't we be asking a question? Surely there are more questions out there, unless you're not asking, because I probably don't have the answer.
Well, I think isn't Dr. Megan Rainey doing some of this work, but like they're looking outside of traditional federal revenue streams for supplementing it because there is this ban. And I mean, I think it's interesting when we usually think about private research, we think of like capitalism and like pharma, like that stuff's not NIH, but why not, continue, especially in times of political stalemating, kind of supporting these other revenue streams. Now, of course, that question then comes into, and I wonder if you had say a gun violence study that looked poorly on guns, that was from a coalition of people that privately raised money for gun violence, does that bias the research? Does that bias the interpretation? Does that bias the translation of that in a way that federal NIH funding is seen as maybe a bit more impartial?
Yeah, it's a great question. And I guess I would counter with any more so than something funded by Eli Lilly. But yeah, I agree, right? I agree. You can, what bias is in there? Yeah. Well, the thing in the chat that Kelly just put in for us is an article that Dr. Cheater wanted me to share with you out of New York. So they have curbed their firearm violence by about 40% by sending out basically not hostage negotiators, but negotiator type people, de-escalation experts, if you will, before the police even arrive. To try to bring down these domestic arguments and such. And so he wanted me to share that article with you. It's an interesting read. It costs a lot of money to do, but by reducing the deaths by 40% sure seems like a worthwhile endeavor to look at.
Yeah, it's
Other
also
questions
interesting
about?
kind of looking at the demographics and how they live. Like the red zoning and like redlining the areas, because I know a lot of the times we usually get like these patient populations from like 5 miles or 2 miles down the street, you know, be just from a certain core aspect of the town. And I just kind of like wonder like if research was kind of put into the cultural type area there, whether it's parks and like recreation areas, like what type of effect that might kind of have on the demographics.
Absolutely. All right. Well, I'm going to close myself and encourage everyone to go ahead and tally what you thought of each of the papers. The prize, by the way, I didn't. So while Kathy's putting up the poll for everybody, I did not announce earlier. The prize for the winner is going to be a free membership in the section for next year, and although it may be a $50 value, it comes with our exceeding gratitude, which is of much greater value. But not only membership for you for the next year, but also free membership for one person of your choosing who's not currently in the section. So loop more people into the section. Please encourage them to be a part of it. And so let's see shortly here who the winner is. I'm going to exclude myself from this. So Dr. Chang, Dr. Klasky, Dr. Lurcher. So there was the TPA based on the perfusion mismatching with Dr. Chang. There was the milrinone dobutamine study with Dr. McCloskey, and the basically DOPA and epinephrine and cold and warm shock with Dr. Lurcher. Go ahead and vote now. It is the most changing article. That's what we're asking, the either practice or research, which is having the biggest impact during COVID.
Andrew, while everyone's voting, I just want to say thank you to all our speakers and thank you for everyone to organizing this. I have to go to night shift, so sorry I have to skedaddle. But thank you for having me and listening to my shenanigans, and awesome job, everyone. Good night.
It's always a better event with you here. Thanks for joining us, Dr. Go. And with that, we should, well, we'll see the winner here, and I'll thank all of our panelists as well. All right, let's do another 10 seconds of voting here because we're after the 9 o'clock hour. Oh, there we go. All right, congratulations, Dr. Chang. Let us know who you want the new member that you want to introduce to the section to be. Thank you, everyone, for oh, wow, how did I even? Well, thank you, whoever one person voted for me.
You voted for yourself.
I did not actually.
Is your mother here again, Andrew?
Must have been. It was a sympathy vote. So thank you again to Dr. McCloskey and Dr. Lurcher, Dr. Chang, and also to Dr. Hines, Dr. Winters, Dr. Gill, and everyone who came. Thank you, everyone, for participating. And look for our next salon to be at AAEM. Dr. Lentz, the chair of the group, do you have anything you want to add as we close out?
No, I appreciate everybody coming. This is great. It's great to see new people, to hear different backgrounds and different parts of critical care. I love it. Thanks for coming.
Hey, when's the section meeting going to be? Any announcement for it in Baltimore?
We have it penciled in person. We also have monthly meetings the first Thursday of every month at 8 p.m. Our in-person meeting will be that Sunday. Kathy will confirm the times for us, but it'll be that Sunday morning. And thank you, Dave.
That voice you just heard was Dr. Schreiber, the first chair of the section back when it was still called president. So thank you for coming, Dr. Schreiber.
Yeah, thanks. Sorry I was late getting on, but I appreciate it. I enjoyed it. Thank you.
All right, great. Well, thank you, everybody. Have a nice night.
Well, I'm
Appreciate
gonna
your
put
time.
a quick
Dr. Winters?
AAEM plug in, Andrew, for our winter Breveloquent event, January 18th with junior speakers. We have 6 junior speakers lined up. It should be really good with topics ranging from driving pressure to retrieval medicine. So should be a great event.
Excellent. Thank you. Very good. And forgive me, I think I missed you with the gratitude. Thank you, Dr. Winters, as well, for being on the panel.
Thanks.
So-
No, I think you got it, Andrew.
Okay, very
and-
good. Didn't want to leave you
and
off.
My pleasure to be here, and I wish everybody a very happy holiday and happy new year.
Wonderful. Well, thank you, everyone. Have a good night.